So, good day, everyone. The topic today is pathology of the mediastinum. The pathology of the mediastinum is an uncommon topic in pathology, but it is very important that we have a good grasp of the tumors involved or involving the mediastinum. First, appropriate therapy for various mediastinal tumors differs considerably according to the histologic type of the tumor, and it may significantly impact on survival. Now, it is not common to see mediastinal specimen. In many centers, what we see usually are the fine needle aspiration biopsy specimens and samples. So, in fact, in mediastinal pathology, there is minimal invasive sampling to establish a tumor, such as a thymic epithelial tumor, and therefore a candidate for resection. So compare that with a lymphoma, in which the surgical resection is not indicated and that chemotherapy is the more appropriate treatment. Now, there are challenges in the surgical pathology of mediastinum. First, there are many different types of lesions, and there is overlapping histologic feature. This is probably the most important aspect or the most important challenge in mediastinal pathology, the difficulty in obtaining good biopsies, which may result to non-diagnostic samples, sometimes inadequate sample, crash artifacts, poor preservations with extensive necrosis, fibrosis, or cystic chains. There are also overlapping histologic features, like the differentiation between thymoma and neuroblastoma, seminoma, metastatic small cell carcinoma, and even lymphoma. It therefore requires significant experience with mediastinal pathology because specimens from this location are relatively uncommon. Now, briefly, let's discuss the anatomy of the mediastinum. When we say mediastinum or mediastinum, it is defined as the space in thoracic cavity between lungs. So you can see the boundaries of mediastinum are posteriorly, you can see here the thoracic spine, anteriorly, the sternum and your costal cartilages, laterally, you have the mediastinal pleura, superiorly, you have the thoracic inlet, and inferiorly, your diaphragm. Of course, there are subdivisions. So a transverse plane passing through the sternal angle to the junction of vertebrae T4 or T5 separates superior from inferior mediastinum, or think of superior mediastinum as above the heart. Space in front of the heart is your anterior mediastinum, and the space behind the heart is your posterior mediastinum. And then the region of the heart is the middle mediastinum. A general differentiation or compartmentalization is that we have the superior mediastinum and the inferior mediastinum, consisting of your anterior mediastinum, the middle mediastinum, and your posterior mediastinum. In this photo, you can see the contents of mediastinal compartments. But for practical purposes, the main contents of your mediastinum for which tumors can arise are the thymus and of course your mediastinal lymph nodes. But let's take a look at the different compartments and the rest of the contents. So we have anterior compartment containing your thymus, your internal mammary vessels, lymph nodes, of course you have connective tissue, fats, sometimes the lower pole of the thyroid and ectopic parathyroid. In the visceral compartment, you can see here the heart, of course, the pericardium, and with all the great vessels involved, the ligamentum arteriosus or PDA, thoracic duct, some nerves, lymph nodes, and anterior surface of your vertebral body. In the posterior compartment, you can have your vertebral body, proximal costal segments of your intercostal vessels, proximal segments of the intercostal nerves and sympathetic chain with its ganglia. In your normal anterior compartments, at least we have four tumors arising from that. We have the thymus, the teratoma, the thyroid, and lymphoma, or shall we say terrible lymphoma. In the posterior compartment, take note that there is a sympathetic chain with its ganglion, so mostly the tumor involved in the posterior mediastinums are of neural in origin. In comparison with the previous slides, this is the anatomic distribution of mediastinal masses. So at the anterior mediastinum, we have your four T's. You have thymoma, your teratoma, thyroid tumor, and of course your lymphoma, but it is called terrible lymphoma, so four T's. And then in the middle mediastinum, you can have your bronchogenic cyst, bronchogenic tumor, your lymph node hyperplasia against the lymphoma, vascular masses, and some pluripericardial cysts. And at the posterior mediastinum, you can have aneurysm, which can cause mass, bronchogenic tumor, enteric cyst, esophageal diverticula, esophageal tumor, and in my experience, these tumors are mostly of neurogenic in origin. This is the WTA histologic typing of tumors of the thymus. The slide is too small, but we can see here there are epithelial tumors, which can be thymoma, thymic carcinoma, can be neuroendocrine tumors, some germ cell tumors, lymphoid tumors, stromal tumors, tumor-like lesions, neck tumors of the thymus or related branchial pouch derivations. You can also have metastatic tumors and some unclassified tumors. Take note of the normal histology of the thymus gland. So a thymus gland is related to your lymphoid tissue or lymph node. So you also have your cortex and you have a medulla. So a characteristic feature of the thymus gland is the presence of Hassel's corpuscles here, which is described like a squamoid appearance in your light microscopy. Now this is a hallmark of your thymus gland. This is the schematic representation of your normal histology of the thymus gland. So basically, the thymus gland contains two major components. You have your lymphocytes or your thymocytes, and you have your epithelial cells, or also called epitheliocytes. So of course, there are characteristic difference between these epithelial cells. So we have subcapsular, which can be a little bit more of a spindle. We have your inner cortical, a little bit rounded, and medullary, which are more rounded compared to your inner cortical. And of course, you have your thymocytes, which can also be subcapsular, cortical, or medullary. Now, these lymphocytes or thymocytes by immunohistochemistry are usually CD3 positive. But take note that if these lymphocytes are of subcapsular type, they are CD3 negative. So it's important to differentiate that. So only the cortical lymphocytes would show CD3 positivity. Now, basically, when we say pathology of the mediastinum, it is most likely the pathology of your thymus gland, because that is the only major organ present in that part of the body. So we have, of course, thymoma. So many surgeons and other clinicians would sometimes mistake thymoma as a benign lesion. So for practical purposes, any type of thymoma or a thymoma is a malignant neoplasm. So thymoma is defined as a low-grade epithelial neoplasm arising in the thymus. The most common primary anterior or the most common location is your anterior mediastinum, specifically anterosuperior. But it can also be present in the neck area, your pulmonary hilum, the thyroid gland, lung, or pleura. So depending on the presence of thymus gland remnants in those organs. Of course, it is the most common cause of a thymic mass. It is more common to those patients above 40. So in fact, you should not strongly consider the diagnosis of thymoma for patients below 40. But of course, it can occur at any age. In general, there is an equal distribution between male and female. Most patients are asymptomatic until the mass is very big, and although they may see the pleural space, pleural effusions are rare. In fact, lymphatic and hematogenous metastases are rare, but up to one-third are invasive. They can invade into the mediastinal fat, into the pleura, pericardium, great vessels, heart, and lung. Take note the associated symptoms in thymoma. In general, thymoma is symptomatic, but however, they can present with some parathymic syndromes. Half of patients suffer an associated parathymic syndromes, and there is a strong association between thymoma and myasthenia gravis. Also, there is association between thymoma and hypogammaglobulinemia, also in pure red cell aplasia. So these are the statistics in the Caucasian populations. 30 to 45% of patients with thymoma have myasthenia gravis. 10% of patients with myasthenia gravis have thymoma. 65% of patients with myasthenia gravis have thymic follicular hyperplasia, and 25% of patients with myasthenia gravis have normal thymus. Since most thymoma are asymptomatic, the most common presentation of the patient is when the mass becomes so big that it causes some compressions of the internal organs. Compressions of your esophagus, maybe your airway, and also other structures within that mediastinum. So gross morphology of thymoma, they are generally uh, rounded and can be very big. It can span from up to around 20 centimeter in the widest dimensions. And on cut surface, they have this characteristic nodular, lobulated, solid, tan brown cut surfaces. But also, sometimes you can see some areas of cystic degeneration, necrosis, and hemorrhage. So again, in this photo, you can see here the typical descriptions of a thymoma. It is a well-circumscribed, solid mass with a tan ivory and lobulated cut surface. Again, just to emphasize, thymoma is a malignant neoplasm, but they can have some benign clinical course. So again, the description is that it is an encapsulated, well-circumscribed, tan, firm, lobulated mass or masses. From microscopic, the span is from about microscopic to over 30 centimeter, but personally, I have not seen beyond 30 centimeter thymoma. I think I've seen 25 maximum. The cut surface shows the lobulated surfaces, and you can see that in the microscope with the presence of bands of fibrous stroma. Now, cystic chains may be extensive, but it is important to sample the cystic wall extensively to search for tumor foci. So a fibrous capsule may be calcified. So those lobulations is due to the thick collagen bands connected to the capsule which divide the tumor into lobules of varying size. So thymoma is a tumor with two-cell population, a mixture of your neoplastic epithelial cells and non-neoplastic T lymphocytes admixed in varying proportion. So again, to emphasize, the neoplastic cells here are the epithelial cells. Now, the epithelial component can be described as polygonal, round, or oval, or also can be spindle shaped. You can see here the typical characteristic of a thymoma on light microscopy, showing a multilobulated architecture with thick fibrous trabeculae that separate the tumor into lobules of varying size. So the tumor is a mixture of your neoplastic epithelial cells and background lymphocytes. Now, before we discuss the different histologic subtypes of thymoma, let's discuss the general features of your most common subtypes of thymoma. So the characteristic features in general about or seen in 70% of the tumor is a prominent dilated perivascular spaces filled with plasma fluid, and they may contain few lymphocytes, plasma cells, or foamy macrophages. You can also see small vessels with hyalinized walls present in the center of these spaces, with the neoplastic cells surrounding these spaces, showing a palisading arrangement. Take note here that the Hassel's corpuscles is present only in 14% of cases. Now, in general, a thymoma does not contain Hassel's corpuscles, but only in 14% of cases. So if you see or you encounter a mediastinal mass with a lot of Hassel's corpuscles, you should probably reevaluate your diagnosis, whether it's thymoma or simply a thymic hyperplasia. The cystic change can also occur in about 19% of cases, and a starry sky pattern can also be present with squamous differentiation. So again, to emphasize, a thymoma usually does not contain Hassel's corpuscles, only in 14% of cases. So if you see Hassel corpuscles, you don't have or you should not consider thymoma unless there are other features present. Other histologic features of thymoma is the presence of storyform pattern, like in MFH, the staghorn-shaped vessels in SFT, the rosette in neuroendocrine tumors, and the gland-like structures or a papillary growth pattern. And you can also see prominent plasma cell infiltrates, microcystic patterns, and sometimes the prominent myoid cells or rhabdomyomatous thymoma. This is an example of a predominantly lymphocytic thymoma. So you can see a lot of immature lymphocytes, and it's very hard actually in this type of thymoma to see the neoplastic epithelial cells. But you have to sample the mass extensively to see the neoplastic epithelial cells. Now this is a mixed lymphoepithelial spindle cell type thymoma. So the epithelial cells here display a spindled appearance with fascicular architecture compared to previous slides which shows a more rounded type of epithelial cells. Now let's take a review of the classification of the thymic epithelial tumors. So Levine and Rosai in 1978 classified thymoma into four groups. We have thymoma, encapsulated thymoma, we have malignant type 1, which is invasive, and the malignant type 2. Now, in 1985, Mueller and Hermelink reclassified thymoma into different subtypes within the group. We have thymoma. In the encapsulated type, we have the medullary type and the mixed type, and the predominantly cortical or well-differentiated carcinoma in the malignant type 1, and in malignant type 2 is a thymic carcinoma. In 1999, the WHO reclassified thymoma now to what we are using in the classification. So we have, in general, a thymoma, and then an encapsulated thymoma. You have type A, type AB, we have type B1, B2, B3, and we have the thymic carcinoma or the type C thymoma. Take note here, the thymoma here in the first group is that this is only applied for a very small tumor. So sometimes very small tumor will not present specific features or very difficult to classify and are simply labeled as thymoma without specific grouping. So this grouping here are usually applied for tumors which are big enough to, to show the histologic features, and you can sample the tumor more extensively. This is a schematic representation of the WHO classification of tumors of the thymus, or specifically your thymoma. So we have different types of thymoma based on the histologic features. You can see here type A is mostly spindle cells with no atypia. So very little lymphocytes in the background. In fact, you have to sample the tumor extensively. In type AB, you have a mix of lymphocyte and also some of the spindle cells. So spindle cells plus lymphocytes. In type B1, this is mostly lymphocytes, predominantly lymphocytes, and very hard to see your rounded neoplastic cells. In type B2, you have an equal proportion almost of your lymphocytes and rounded neoplastic epithelial cells. And to some degree, an atypia is already present. In type B3, you can see the palisading perivascular sinus, and also you can see a lot of atypia already in type 3 or in type B3. This study was done in 2006 by one of our residents. This is entitled The Prognostic Usefulness and Clinical Pathologic Correlation of Thymoma based on the new WHO classification from the Philippine Heart Center experience from 1976 to 2004. Well, basically, this is a duplicate study, but we don't have a lot of thymoma samples in the Philippines. And in fact, there is a direct or almost direct correlation between the histologic subtypes and the prognosis of the patient. In other school of thoughts, they said that the histology of the thymoma does not correlate clearly with the histologic features, but more on the staging. But that is an obvious perspective. Of course, the staging will always follow the clinical condition of the patient. So if it is a thymoma but it is already invasive, regardless of the histologic features, then that should be considered to be an advanced disease. Now, this is another um, schematic representation in the classification of your thymoma, basic facts for residents. So we have type A thymoma, type AB thymoma, so type B1, B2, and B3 showing the percentages present here. Now I think this is the easier table to remember the classification of thymoma. So a type A thymoma, you have oval to spindled cells, usually spindle cell thymoma with very little lymphocytes. Type AB, you have oval to spindled cells, small few lymphocytes. So this is lymphocyte-rich spindle cells, even if the lymphocytes are just small in amount. And then you have B1, round epithelial cells, or T lymphocytes. So this is a lymphocyte-rich thymoma. B2, we have numerous epithelial cells with multiple small lymphocytes. So almost equal populations of your epithelial cells and lymphocytes, or the lymphoepithelial thymoma. And in B3, you have sheets of large epithelial cells and scant lymphocytes. So atypia is already present. So this is called your atypical thymoma. Now this is your diagnostic algorithm to classify thymoma. So you actually have to evaluate the two components. You have the lymphoid component and epithelial component, and simply based on the different patterns, you can classify that into different types: A, AB, B1, B2, B3, or a thymic carcinoma. Again, another classification of thymoma based on Thymoma morphology. So type A, spindle cells with elongated nuclei and granular chromatin pattern. Type AB, mixed spindle cells and occasional epithelial cells and some lymphocytes. B1, predominantly lymphocytes. B2, almost equal proportion of lymphocytes and rounded polygonal epithelial neoplastic cells. And B3, of course, is the presence of nuclear atypia. We are seeing here a closer magnification of your type A thymoma. So you have spindle epithelial cells here with lymphocytes, very few lymphocytes. Take note that in type A, even if this is predominantly a spindle cells, there should always be the lymphocytic component from elsewhere. So it's important to sample these extensively because the absence really of lymphocytes may not help or support your diagnosis of thymoma. And in fact, that could be a sarcoma or some spindle cell lesions. So important really to see the two features, the presence of neoplastic epithelial cells and background lymphocytes, no matter what are their proportions in different areas of the tumor. So the major differential diagnosis of a type A thymoma is your type AB thymoma and some other non-epithelial malignancies like synovial sarcoma or solitary fibrous tumors. So the immunohistochemistry here is you have to do TDT, and it's positive in more than 10% areas with moderate TDT or any dense area. Um, that could also that could be considered to be an AB thymoma. Now this is your type AB thymoma showing here the uh, A and B type star or type of lobules. So you can see here again some of the spindle cells here, and now we have more prominent lymphocytes in the background. So in type AB thymoma, usually it is not required for diagnosis, but you can always do that. You have pan-CK, you can do pan-CK, the TDT, and also CD20. But this is not required in the diagnosis. So some of the lymphocytes can be positive in CD20, but in general, as I mentioned earlier, the supporting lymphocytes is usually CD3. But again, the immunohistochemistry is not required in the diagnosis. This is your B1 or predominantly lymphocytic thymoma. So as you can see here, this can be mistaken for a lymphoma, so a lot of lymphocytes, and only if you check or sample the tumor more extensively, you can see some of the polygonal or rounded neoplastic epithelial cells. Your major differential diagnosis of your type B1 thymoma can be a thymic hyperplasia, a type B2 thymoma, and also sometimes lymphoma because of a lot of lymphocytes. Now this is a B2, a combination of your polygonal neoplastic epithelial cells plus your lymphocytes. So there's an abundant epithelial cells here with irregular nuclei and some of the lymphocytes in the background. Your B2 thymoma again usually is not required, but you can do here some CK, now again CD3 and TDT. We have type B3 thymoma, which is polygonal epithelial cells with irregular nuclei. So this is the type of thymoma showing already some degree of atypia in the polygonal neoplastic cells. So type B3 thymoma, your major differential diagnosis here is your type B2, and also you can also, or this can also be mistaken for your thymic squamous cell carcinoma sometimes. In the immunohistochemistry, you can do CD5, which would be negative, CD117 negative, and TDT, well, it can be positive or negative. So you can rule out here if these are all negative. This you can rule out carcinoma in your differential diagnosis. And then you have your thymic squamous cell carcinoma, which, because that is a differential diagnosis for your B3, um, the other differential diagnosis for thymic squamous cell carcinoma is your metastatic lung or an ENT carcinoma. So you should do again CD5, CD117, or TDT. Now, in general, we could say that from those paper, we can say that the histologic subtypes correlate with the prognosis. So the A has the best prognosis, and of course, the B3, of course, towards carcinoma has the worst or more aggressive clinical outcome or poorest prognosis. But in general, you should always consider the clinical staging of the patient rather than relying solely in the morphology. So for clinical decision, however, it is important to separate the two because type A, AB, and B1, they are usually indolent and of low stage. And from B2, B3, and of course to carcinoma, these are aggressive. So the challenge really is how to separate B1 from B2. And again, um, for a more clinically relevant decisions, of course, as I mentioned earlier, all thymomas are malignant. But again, if we are pushed to the limit, it is important at least to differentiate or to separate B3 from your carcinoma, which is very, very challenging actually. Sometimes the features overlap and sometimes they are present in one specimen. So probably for general pathologists, at least learn to differentiate a B3 thymoma from a carcinoma. So what are the prevalence and prognostic features of the subtypes? So type B2 and AB each is 20% to 35% prevalent. B1, B2, and type A are basically rare, about 5 to 10%, and type C about 10% to 25%. So if you encounter thymoma, it's probably just between B2 and AB. Now the prognosis, although the prognosis correlates heavily with the histology, the most relevant factors are still your tumor stage, combine that with your WHO histologic type, as well as the resection status, of course, because if the margins are positive for thymoma, then there's a tendency for recurrence. So type A and AB thymomas in stages 1 and 2 almost always follow a benign clinical course. So I put here quote unquote benign, but again, just to emphasize, all thymomas are malignant. Your type B1 has low malignant potential, but there is a tendency for local recurrences and metastasis may occur even after 20 years. While type B2, B3, and of course type C or the carcinoma are clear-cut malignant tumors. So we have discussed the different prognostic factors, which are multifactorial, but take note that invasion is the most important. The best determination of invasion is by the surgeon at the time of operation, better than CT imaging. So it's important that even a well-encapsulated tumors should be inked at the time of gross evaluation. Another sign of possible invasion is the presence of islands of thymoma in perifatty tissue. Now, during the operation, the surgeon should be able to identify if thymoma is adherent to adjacent structures. So the surgeon should designate the site of adhesion on the specimen so the pathologist can take careful section of that area. Sometimes an inflammatory fibrous reaction can also lead to false impression of tumor invasions. So it's important. I think the most important really here, even a type A thymoma, is the completeness of resection. Now, if we disregard the presence of histology subtype of thymoma, we have what we call the classification called invasive thymoma. So this is mainly uh, a classification based on the gross analysis or gross evaluation of the surgeon. So, or sometimes through the CT scan or other imaging studies, when the tumor is showing um, adherence or invasion to the adjacent structures like the heart or the lungs, that can be considered as an invasive thymoma. Or and sometimes in the microscopic evaluation, you can see here there's invasions in the perifatty tissue. So this is already considered as an invasive thymoma, regardless of the histologic subtype, even if this is a type A, which have A or AB, which have a benign clinical course, but there's already the presence of tumor in the perifatty tissue that is already called an invasive thymoma, and the staging can change the prognostication of the patient. So this is the descriptive features of an invasive thymoma. It appears on CT scan as an irregular, ill-defined mass. Additional findings of invasion of adjacent mediastinal structures, chest wall invasion, or contiguous spread along pleural surface. There's also direct contact and absence of cleavage planes, but these are not strict reliable criteria to predict the invasions. Also, clear delineation of fat planes surrounding a tumor should be interpreted as indicating an absence of extensive local invasion. In my experience, the invasive thymoma is usually from the judgment of the surgeon with sometimes findings from your CT scan. So this is another example of an invasive thymoma. Uh, this is a thymoma from which can be A, AB, or B1, but take note that during the sampling you can see some infiltration of the thymoma in the skeletal muscles. So this is already an invasive thymoma, and the histologic subtype will not matter in the prognostication. For staging purposes, thymomas can be divided into encapsulated, invasive, or metastatic. So the invasion can be gross or microscopic. Of course, one of the criteria for the microscopic is the presence of thymoma in the perifatty tissue as well as invasion of the capsule. Take note that invasion also needs to be transcapsular with microscopic invasion into adjacent mediastinal tissue before it impacts upon outcome. In our center, we currently use the clinical staging of thymic epithelial tumors using the Masaoka classification or staging. So this is your Masaoka Koga staging system, which we use in the microscopic staging of the thymoma. So I'm not exactly sure if the surgeons would follow this in the treatment or in the prognostication and management of the patient, but we do still report this for all of our thymoma specimen. So stage 1, you can see here, capsule is absent but no invasion. There's also separate nodule within the capsule, and there can be direct intracapsular spread. In stage 2A, you have limited microscopic transcapsular invasion. So this is based on your microscopic evaluation. Stage 2B, localized gross invasion limited to your mediastinum. Stage 2B, more extensive invasion but limited to mediastinal fat. Stage 3, direct mediastinal involvement or partial pericardial or vessel invasion. So this is the higher stages, especially stage 3, requires also the output, or rather the input from your surgeon. And stage 3, direct penetration through visceral pleura, pericardium, or vessel. So you can only evaluate this if there are other structures submitted along with your thymus specimen. Stage 4A, there's already a pleural nodules, pericardial nodules. And stage 4B, of course, there's distant organ involvement. So also the AJCC have their own classification derived from your Masaoka-Koga staging system. But I I saw some previous studies that the Masaoka-Koga stage correlates well with the prognostic or the clinical outcome of the patient. But in your global pathology community, we always follow some of the AJCC classification. But in our center, in the Philippine Heart Center, we do Masaoka Koga staging. So what are your differential diagnosis of thymoma? In my experience, the most common really is a malignant lymphoma, especially for B1. So you can use the keratin stain, maybe at least for a start, do a CD3, CD20, and at least do your pancytokeratin. So the pancytokeratin should be negative, of course, and there should be some monoclonal um, staining pattern of your CD3 or CD20. And also, when diagnosing thymic carcinoma, such as SCC, you should also consider first the possibility of metastasis rather than a primary thymic neoplasm, which we all know how to do that. So this is more of a clear or a thorough clinical history and ideally a more complete imaging studies. How about thymic carcinoma and thymoma? So in general, the thymic carcinoma looks entirely different from your thymoma. So a thymic carcinoma can be actually of any type. You can have squamous cell carcinoma, which they can look very similar to your squamous carcinoma elsewhere. It can be an adenocarcinoma also, which they can look very similar to any other adenocarcinoma elsewhere. But also from our experience, it can be found synchronously or may develop within a pre-existing thymoma after an interval of 10 to 14 years. But mostly these are de novo. So your thymic carcinoma will show highly atypical cells with cytoarchitectural features of carcinoma similar to those seen in other organs. They lack encapsulation, presence of invasion and metastasis, and also presence of cystic degeneration and necrosis and mucoid cut surfaces. Many lymphocytes can be seen also in thymic carcinoma, which can be B cells, mature T cells, but not immature T cells. It fails to recapitulate the features of normal thymus, as I mentioned earlier. And these also express CD5, unlike your type A, AB, and B thymomas. So a thymic carcinoma can look like anything, squamous, adeno, and other subtypes. You just have to prove that the tumor arises from your thymus. So sometimes you can see remnants of the thymus, normal thymus histology, and sometimes after extensive sampling, you can see areas of thymoma. So showing here what is the main difference or the differences between a thymoma and thymic carcinoma. So thymic carcinoma, the neoplasm of the thymus arising from its epithelial cells are known as thymoma. Thymic carcinoma are the malignant tumors arising from the epithelial cells of the thymus. So benign versus malignant. Now, I think this slides is a little bit misleading. So thymoma can either have benign clinical course or a malignant clinical course. I mentioned earlier, thymoma is always malignant. Thymic carcinoma are always malignant as well, and the clinical outcome is always a malignant. Most symptoms are due to the impingement of the adjacent structure by the enlarging mass. So the presentation could be your dysphagia, cough, chest pain, changes in the voice, but also the symptoms of your myasthenia gravis. In thymic carcinoma, in addition to the symptoms of a benign thymoma, The other symptoms of thymic carcinoma can have your constitutional symptoms similar to your other malignant tumors, just loss of weight, loss of appetite, malaise, and bone pain. So the management, in general, the most common management of any thymoma is to resect the tumor or thymectomy. While in thymic carcinoma, it's always followed by radiotherapy after your thymectomy. So we have within the thymic carcinoma spectrum, you have low grade and high grade. So of course, as in any other tumors, your well-differentiated tumors have better clinical outcome. So your squamous cell carcinoma, mucoepidermoid carcinoma, and maybe basaloid carcinoma. Your high-grade tumors, of course, have poor outcome, but these are all malignant. So your lipoepithelial-like carcinoma, mucoepidermoid carcinoma, clear cell, sarcomatoid, and anaplastic could have rapid response. In my experience in general, most thymic carcinoma that I have encountered really led to death of the patient. And then we have this entity called the well-differentiated thymic carcinoma, when they show a well-differentiated squamous cell or adenocarcinoma. But this is still a very controversial, entity because in general, even a well-differentiated squamous cell carcinoma in the thymus can have a poorer outcome, especially because of the location. And in general, when they are resected, they are already develop invasion to the different organs within the compartment. So this is an example of a squamous cell carcinoma in the thymus, a poorly differentiated one with highly atypical cells with enlarged nuclei and, of course, prominent abnormal mitosis. So A is a squamous cell carcinoma here, probably well differentiated. B is a high-grade undifferentiated carcinoma, which look like or similar to the nasopharynx, as well as in C, lymphoepithelioma-like carcinoma, and you have the spindle type or sarcomatoid carcinoma, which can mimic your high-grade sarcoma. Other high-grade tumors, your mucinous adenocarcinoma, your papillary carcinoma, your clear cell, your rhabdoid carcinoma, and your anaplastic carcinoma. So again, let's differentiate the two thymic carcinoma versus thymoma. Macroscopically, your thymic carcinoma would be large, firm, infiltrating masses with frequent areas of cystic chains, areas of necrosis, hemorrhage. They can be encapsulated in 15% of the cases. And usually the presentation is similar to your constitutional symptoms from malignant tumors from other organs. So thymic carcinoma would not present with paraneoplastic syndrome, no immature T lymphocytes, no lobulated pattern. Instead, if the cut surface would show a desmoplastic stroma, maybe areas of extensive necrosis and hemorrhage, and no characteristic histologic features like your perivascular space, medullary differentiation, and again, no Hassel's corpuscles. Now, in contrast, it's important to differentiate thymic carcinoma from metastasis. In fact, you should first consider a metastasis before a thymic carcinoma. But then there are no histologically pathognomonic features that can differentiate the two, so you have to correlate everything, including the clinical findings. So if you find an obvious transition from a pre-existing epithelium as the same principle from any other tumor, you can consider this as a thymic primary. There are some special variant like the basaloid carcinoma with cystic changes, carcinoma with rhabdomyomatous cells, which can suggest that this is a thymic carcinoma. So in general, your primary thymic carcinomas are rare, so you have to consider a metastatic foci first before thinking of the primary. In the clinical evaluation, search for a primary tumor, especially lungs, which you can do if you have to perform extensive IHC studies, which are your CD5, 80% is positive in thymic carcinoma, negative in thymoma and metastasis. You can also do c-KIT and GLUT1, which are all positive in thymic primary. Your TTF1, of course, is positive in lung cancer, negative in thymic carcinoma. A high frequency of p53 protein expression has been reported in thymic carcinoma but not in thymoma. And your BCL2 and p53 are signs for more clinically aggressive tumors. So your prognostic implications of histology, you have low grade and high grade, the same as in other tumors. You have to evaluate for the infiltrative growth or tumor margin, absence of lobular growth pattern, high grade nuclear atypia, necrosis, and more than 10 mitosis per 10 high powered fields signifies a high grade thymic carcinoma. Now in general, in other center which are not performing um, thoracic surgery, most likely you will encounter cytology of the anterior mediastinal masses. So of course you should also always do the three tests. You have the clinical history, the radiologic findings, and cytomorphology. So here you can see round to oval cells, lymphocyte rich, probably a thymoma, this cohesive, probably a lymphoma. And then you can also see here some spindle cells. If it is spindle cells, always also consider a thymoma in the A or AB type. If it is pleomorphic or none otherwise specified. And the fourth component is you have to do some ancillary studies. I would think that the patient would still appreciate if you do the ancillary studies, because the FNAB of the mediastinum is a very difficult process in general, and a lot of times we receive either inadequate specimen or non-diagnostic aspirate. So you have to consider a lot: clinical findings, morphology, and radiology. So location, we have anterior, you have consider the 4T, thymoma, teratoma, thyroid, or the terrible lymphoma. Middle, probably lymphoma or metastatic tumors. Superior can be thymoma or lymphoma, and then posterior usually are neurogenic tumors, just ganglioneuroma or ganglioneuroblastoma. You also have to consider the age. If they are young, do not consider thymoma first. So usually for young, consider a lymphoma or a germ cell tumor in case of male. For middle age, maybe above 40, you can start considering thymoma. And for older people, probably they are metastatic. Now for thymic carcinoma, they can develop across ages, but usually in the elderly. So the symptoms can also vary depending on the etiology of the tumors, and always correlate with the radiologic findings. So again, another algorithm for FNA. So probably for general pathologists, these are the most important evaluations, and also important to do the relevant immunohistochemistry stains. So here you can see here around cell morphology, depending on the locations, you can consider thymoma, germinoma, non-Hodgkin lymphoma, Hodgkin, or metastatic small cell. If it is a spindle cell morphology, again thymoma, which can be A or AB, a neurogenic tumor, especially if presence in the posterior aspect or mediastinum. You can also have a spindle cell squamous cell carcinoma, also melanoma, always a consideration, and lymphoma. This is my study about 6 years ago, a correlation of fine needle aspiration cytology of thymic epithelial neoplasm. It's very we have very, very few studies in the aspiration of thymic epithelial neoplasm. And in this sample, we only have 21 cases over I think 10 years. So we still have our conclusion is that the final aspiration cytology of thymic epithelial neoplasm still correlates with the histology. So in this paper, we compare the FNAB of a particular specimen compared to the final diagnosis based on the resection specimen, and we were able to correlate the tumor. But of course, we were not able to type this. We only divide the tumors into as a thymoma, um, a thymic epithelial, or a thymic carcinoma, or a neuroendocrine tumors, or a thymic carcinoid. So just simply the thymoma, thymic carcinoma, or thymic carcinoid. But it's impossible to subtype your thymoma in final aspiration cytology. So another tumor in the thymus, of course, your neuroendocrine tumors, which or the NET, which you can also see in different organs like pancreas or testis or uterus. So you can also encounter a well-differentiated neuroendocrine tumors at your typical carcinoid or atypical carcinoid, which can be differentiated based on your mitosis or your K67 expression, and a poorly differentiated carcinoma. So in the Philippine Heart Center, probably we encountered maybe 5 or 6 thymic carcinoid. It's very uncommon, 2% mediastinal and 5% thymic. So we wonder what is the origin of this 2%? Well, there's a 5% thymus and 2% mediastinal. Probably there are others. They can arise probably in other structures present there, like your fatty tissue, connective tissue, blood vessels. But in general, it's from the thymus. So in adults, the mean age is about 50 years, male preponderance. They are usually associated or rarely associated with carcinoid syndrome. Can also be associated with your Mann-Cushing syndrome. It varies in size from 1 to 18 centimeters. It can be well circumscribed or encapsulated or not. So the evaluation, the classification of carcinoid as typical, atypical, or sometimes small cell carcinoma is also similar to the neuroendocrine tumors found elsewhere, like in the lungs or pancreas. So it also have the same morphology as those tumors. We have the organoid nest, trabeculae, rosettes or palisading, homogeneous cytologic features with finely granular nucleus. Uh, it's important, of course, again here is to just to prove that the origin of your carcinoid is really the thymus and not a metastasis from the lungs or other organs. So you can see here organoid nest composed of uniform polygonal cells. Presence also of a lot of mitosis here. You can see which are some of those criteria to classify a neuroendocrine tumor as a typical or a small cell carcinoma. Now this is again a thymic carcinoid um, showing the organoid pattern, and of course very important to do here immunohistochemistry. First, of course, is to your mitosis, which are best differentiated or delineated by your Ki67 or other proliferation marker. Of course, if it is a very high grade neuroendocrine carcinoma, that can be a small cell carcinoma. Sometimes it's when the Ki67 is beyond 20%, you should start considering small cell neuroendocrine carcinoma. Again, it's a rare primary thymic lesions similar to its counterpart in the lungs and elsewhere. But since the proximity of the lungs with the mediastinum should be considered, then consider first a lung metastasis. And then, of course, the immunohistochemistry here, you have to do cytokeratin and ideally at least 3 of these markers, your chromogranin, CD56, or synaptophysin. And in electron microscopy, they would show your dense core granules. Other germ cell tumors which you should consider with a male patient young in their 20s or late teens. This can be an isolated metastasis from occult primary gonadal neoplasm or really from the mediastinum. So you should also, because it can account to 10% of all germ cell tumors in men, or it can be a metastasis, and because it can spread via lymphatics but can metastasize elsewhere like choriocarcinoma. So important to do your serum AFP or HCG, and there are also some strong association with hematologic disorders in many cases. And other germ cell tumors to consider, of course, are your teratoma, the most common. It can occur in children and young adults. So the same germ cell tumors you can see in testis and in ovary, usually asymptomatic, but if large enough, can cause mediastinal compression. So in general, the tumor of the mediastinums are asymptomatic, especially if they are non-thymoma. But when they are very large, of course, they present with mediastinal compression syndrome, sometimes difficulty of breathing. So the teratoma can be, of course, this is benign, well differentiated, but they can also be immature and contains more than 50% immature components, and of course that can recur or can metastasize. So when a mature teratoma contains focus of a carcinoma, sarcoma, or malignant germ cell tumor, it is a malignant teratoma. So you have to consider that you can have here a benign teratoma, an immature teratoma with immature components, or some focus that could be a teratocarcinoma. Other germ cell tumors can be seminoma, embryonal carcinoma, your yolk sac tumor, choriocarcinoma, malignant teratoma, or mix. So again, this can be a metastasis from the testis or ovary, or they can arise in your thymus as a primary mediastinal germ cell tumor. Of course, a very important differential diagnosis in any mediastinal tumor is the consideration of hematologic disorders. So in lymphadenopathy, the cause of course depends on the patient age. So aside from your germ cell tumor, lymphoma should always be considered in patient below 40 years of age. Of course, they can occur across ages. So a lymphadenopathy in imaging can be a metastatic carcinoma. It can now a lymphoma or some infectious or inflammatory conditions. In our setting, again, the most common inflammatory conditions involving the mediastinum is your tuberculosis, and to some extent some fungal infections like Isoplasma and sarcoidosis. So again, in the Philippine Heart Center, we also see a lot of presenting mediastinal mass, and during FNAB, the mass is found out to be tuberculosis, probably extending from your lungs. So again, lymphoma, it can involve the mediastinum. Probably, in my experience, this is the second most common tumors after your thymoma. But here, the commonness of the mediastinal masses are, so you can have your nodular sclerosis, Hodgkin disease. Basically, these are, if you encounter a patient, a young patient, a woman with a mediastinal compression, and the clinical history would show a repeated FNAB and only shows fibrosis or some stromal cells, consider nodular sclerosis Hodgkin disease. But of course, you need to do a thorough workup and an adequate biopsy. A lymphoblastic lymphoma can also occur, especially in children, can grow very rapidly. And you also have your diffuse large B-cell lymphoma, which can occur at any age, and some low-grade B-cell lymphoma. Now we have so-called the primary mediastinal Hodgkin lymphoma. So Hodgkin lymphoma in general is very rare. Well, it's rare, but when it is present in thymoma, it's even probably very remote consideration. But the presentation is that an incidental mediastinal mass on chest X-ray. It's usually very large, maybe cystic, and cause some retrosternal chest pain, cough, dyspnea, effusion, or superior vena cava syndrome. You can also have these symptoms, pruritus. So take note, of course, in Hodgkin lymphoma, that you see a mixed inflammatory background. So when you see eosinophils, at least in my experience, I would consider Hodgkin lymphoma. And of course, you need immunohistochemistry to support this diagnosis: CD30, CD15, CD45, CD20. And of course, your differential diagnosis here is your large B-cell lymphoma. Your lymphoblastic lymphoma is a very aggressive high-grade lymphoma. It can occur as a rapidly enlarging mediastinal mass, which may cause compression of mediastinal contents. It is similar to ALL. It resembles cortical lymphocytes morphologically and immunophenotypically. So you have a double CD4 positive, CD8, CD1A, or TDT. Then we have a primary mediastinal large cell lymphoma. So before, this is under the umbrella term diffuse large B-cell lymphoma. So before, when we encounter a lymphoma from the mediastinum, we just differentiate that into Hodgkin and non-Hodgkin. And then under non-Hodgkin, because most of the cells that we encounter in mediastinum or mediastinal lymphoma are large, they are simply classified as a diffuse large B-cell lymphoma. But now we have this is a separate entity still under the diffuse large B-cell lymphoma, but it's important really to differentiate this as such specifically, and it requires some marker. There are no specific marker for here, but there are pertinent positive and pertinent negative. So this is usually from the third decade. It presents as a rapidly expanding mediastinal mass which may invade the airway, chest wall, or adjacent structure. It's mostly B cells, positive for B cell markers such as CD20, CD30, CD5, and are negative for cytokeratin. Your differential diagnosis here could be your perivascular position thymoma, entrapment of normal tissue, or artifactual cytoplasmic clearing of a seminoma. So it is still in the WHO classification. It is still under the umbrella term of diffuse large B-cell lymphoma, but it is a separate entity on its own, and because they are closely resembling your seminoma. And in non-Hodgkin lymphoma of the mediastinum, you should also consider first a metastasis before considering a thymic primary. I mean, in general, with the exception of a thymoma, other malignant neoplasm in the mediastinum, you should consider first a metastasis before primary, because these are very rare. So there are other findings that you can do to yield a specific diagnosis of primary mediastinal large cell lymphoma, which I will not emphasize here really. So you need some flow cytometry, some gene arrangement studies, and cytogenetics to really classify this as a primary mediastinal large cell lymphoma. because the immunoprofile is a little bit different than a diffuse large B-cell lymphoma. What about their mesenchymal tumors? So, because the lymphoma, or the mediastinum rather, contains other structures, blood vessels, connective tissue, fats, you can also develop other neoplasm like lymphangioma, hemangioma, lipoma, and even sarcoma. So in the anterior mediastinum, the mediastinal goiter can also be present because the inferior pole of the thyroid normally lies superior to the thoracic inlet. So growth through the thoracic inlet can produce symptoms related to compression of normal thoracic inlet contents. So these are mostly benign, multinodular goiter and large follicular adenoma accounting for 95%. Large multinodular goiters have little functioning tissue, usually cystic. Usually you can develop cystic degeneration, fibrosis, calcification, and hemorrhage. And in some rare instances, you can develop papillary thyroid cancer. You can also have parathyroid masses for ectopic parathyroid adenomas here. So how do you differentiate basically a parathyroid hyperplasia from a parathyroid adenoma? So in a parathyroid hyperplasia, all four parathyroids, of course, are enlarged. In parathyroid adenomas, it's only one or maximum of two. So the other glands, parathyroid glands, are normal. Then we have your neurogenic tumors, which should be the first consideration for masses in the posterior mediastinum. So any of this can develop in that part of the mediastinum. So tumor of the sympathetic nervous system, your neuroblastoma, usually ganglioneuroblastoma, ganglioneuroma. You can also have schwannoma in that area, neurofibroma, or malignant nerve sheath tumors. So here you can see this is our ganglioneuroblastoma here. So we have some of the ganglion and the spindle cells. Of course, you have this schwannoma of the Verrucae body cell, Antoni A and Antoni B. What about the mediastinal cysts? So these are again your benign counterparts, mostly benign and incidental imaging. They are present usually labeled as a thymic cyst. So the most anterior common types, you have the thymic cyst, cystic thymoma, parathyroid cyst, lymphangioma, cystic teratoma. You can also have pericardial cyst, bronchogenic cyst, or gastroenteric cyst. So the classification is based on the lining here. So superior, you have thymic cyst. So if you see remnants of thymus gland, remnants of parathyroid, and in the anterior mediastinum, you have thymic cyst, parathyroid cyst. In the middle, you have the bronchogenic, pericardial, enteric, thoracic. And the posterior, again, neuroenteric, thoracic, and mediastinal cyst with Mullerian differentiation. Now, in summary, this lecture discussed the interpretation of pathologic specimen from the mediastinums, which requires familiarity with a wide range of neoplasm and care for clinical correlation. It is critical for surgeons, radiologists, and pathologists to communicate well. If tumors originally treated by non-surgical means do not respond as expected, consider additional biopsies, special studies, or consultation may be necessary to achieve the correct diagnosis. Thank you.